Hello, my name is Tiffany Truong. I am a third-year medical student at the University of Nebraska Medical Center, College of Medicine, and this is Medication Mayhem, a Skinteresting consult. Adverse reactions to medications often present with involvement of the integument. They are characterized by the rapid change of skin appearance, such as erythema and dryness, and associated symptoms, such as pruritus, culminating in a visible rash. The challenge for physicians is to determine the etiology of such rashes in order to effectively treat them. Often, cessation of the offending agent resolves the rash. Our patient is a male in his 8th decade of life with bilateral lymphedema and over 30 episodes of cellulitis who was started on 250 milligrams penicillin VK BID for prophylaxis. 11 days later, he developed a symmetric, erythematous, scaling rash on his buttocks and perineal region with associated pruritus and bleeding. He denied any fevers or chills. The patient tried multiple over-the-counter medications for the rash without relief. Further medical history included chronic kidney disease, heart failure, hypertension treated with amlodipine, and overall body cirrhosis. The timeline of our patient's case is restated here for clarity. The patient had a long-standing history of bilateral lower leg lymphedema and cellulitis. He was treated for his most recent episode, then put on 250 milligrams penicillin VK BID for prophylaxis. At the time, the patient was also on 10 milligrams hydroxyzine QID, as well as many other medications for his chronic conditions. As a result, he developed a rash and pruritus 11 days later, and dermatology and infectious disease were consulted. On physical exam, skin examination demonstrated diffuse lichenified plaques with marked fissures, scaling, and crusting on the buttocks. The patient's symptoms were attributed to symmetrical drug-related intertriginous and flexural exanthem, or SDRIFE, a systemic drug-related contact dermatitis characterized by symmetric, well-demarcated patches of erythema on the buttocks. This condition is also known as baboon syndrome due to its characteristic rash similar to the markings of a baboon. This can be caused by agents such as penicillin, hydroxyzine, and cashews, all of which the patient was exposed to. This condition is very rare, with only about 100 cases described since its discovery in 1984. The pathogenetic mechanisms of SDRIFE are still unclear, but two theories have been proposed. One is that SDRIFE develops as a result of a type 4 delayed hypersensitivity immune response. This notion is supported by immunohistochemical evidence for CD4 positive T cell infiltration and increased endothelial and keratinocyte expression of CD26 p-selectin, which recruits type 1 helper T cells to sites of inflammation. According to some studies, SDRIFE likely involves both a type 4A hypersensitivity reaction with CD4 positive Th1 cells and macrophages, as well as a type 4C hypersensitivity reaction with cytotoxic CD4 and CD8 T cells. However, this theory does not explain the occurrence of SDRIFE after the first exposure to a given drug without prior sensitization. The second theory describes a reactivation of tissue toxicity at the intertriginous predilection sites, direct interaction of the drugs with immunoreceptors, and anatomical particularities of the large folds due to the abundance of eccrine sweat glands. This has been termed recall phenomenon. Many other drugs can cause SDRIFE. The most common culprits are beta-lactam antibiotics such as amoxicillin, while anti-infectious agents and topical agents listed here have also been reported. The diagnosis relies mostly on clinical presentation and history, as well as the exclusion of other causes for a rash. Laboratory investigations are performed to exclude systemic involvement, such as cytopenia or hepatic or renal involvement, but are otherwise not necessary for the diagnosis of SDRIFE. Patch tests, lymphocyte transformation tests, and drug provocation tests can be useful for diagnosis, but the outcomes of these tests are highly variable. Skin patch tests are usually the preferred means of testing as they apply directly to previously affected areas. According to peer-reviewed studies, a patch test gives a positive reaction in up to 50% of patients. The explanation for these results may be the fact that the systemic agent is not completely absorbed when applied to the skin during patch testing. Controlled drug provocation testing is considered the gold standard clinical test and gives a positive result in most patients with SDRIFE. Positive drug provocation testing have been reported for cases of SDRIFE with clindamycin, cimetidine, corticosteroids, terbinafine, and valacyclovir. The infectious disease team recommended the discontinuation of penicillin VK and hydroxyzine. The patient was switched to triamcinolone 0.1% ointment BID and clobetasol 0.05% ointment BID to the affected area with petrolatum for xerosis. A follow-up appointment with dermatology demonstrated marked improvement. Currently, recurrence of rash upon rechallenge is not well documented. For our discussion, it is important to note that erythema and pruritus following initiation of a new medication is often indicative of an adverse reaction. Rashes from penicillin and hydroxyzine in patients without a history of previous reactions are less common, but should also be considered. In this case, correlation of the rash with the administration of penicillin and hydroxyzine, as well as the infrequent ingestion of cashews, prompted cessation of the offending agents. However, diagnosis was delayed until these physical signs became evident. Additionally, the paradoxical reaction of hydroxyzine is typically overlooked as a culprit for pruritic rash given its intended purpose of minimizing pruritus. In conclusion, this case underscores the value of a thorough history and physical in combination with a broad differential in the diagnosis of pruritic rash and highlights the value in understanding polypharmacy and medical reconciliation rather than adding agents when symptoms continue to arise. These are my references, and this is my final slide. Thank you so much for listening, and I'm happy to answer any questions you may have.